Good day, everyone. My name is Lucia Udeoji. I am a doctoral candidate for psychiatric mental health nurse practitioner program. Welcome to my project presentation. I'll be talking to you today about the application of a depression screening instrument called a Quick Inventory on Depressive Symptomatology in an inpatient adult psychiatric unit, with the goal of reduction of readmission rate, especially the 30 days readmission rate. Thank you so much for taking your time to listen to me today, and I hope you learned something from this presentation. Looking at the abstract, an abstract just gives you a little overview of what the project is all about. Okay, let's just delve a little bit into the background. Readmission rate is used to determine the quality of care in psychiatric setting. That means that the rate at which patients keeps returning to your hospital or your facility for the same issue determines whether you are actually providing effective care or not. Literature correlates comorbidity of depression and physical illness to high 30-day readmission. Readmission causes decline in patients' quality of life. It increases healthcare costs and causes enormous disruption in the family system. The purpose of this quality improvement project is to determine whether prompt screening for this comorbid illness with a reliable and valid instrument called the Quick Inventory of Depressive Symptomatology, SR16, will help in the reduction of the readmission rate. Let's talk a little bit more about depression. What is depression? Depression is a mood disorder that always occurs comorbidly with other illnesses and therefore mostly go undiagnosed because it's always masked by other diseases. One of the contributing factors for this myth is because it presents differently in different individuals. And also there's this myth that this illness is a normal aspect of human nature. No, it's not. It has been indicated in many studies that this illness increases the burden of disease globally. This means that it increases the financial cost, mortality, and morbidity of diseases. The World Health Organization stipulates that depression is one of the leading causes of disability globally. Study by Clark and colleagues in 2016 indicates that productive years lost due to this illness is much greater than diabetes and cancer. This is really disturbing. Also, it is shown in different literatures that patients with mental health issues has 56% chance of getting readmitted than those without mental health illness. As we can see, the current COVID-19 pandemic has increased the level of mental health care seeking from individuals. Literature also indicates that patients with underlying comorbid depression with medical issues like congestive heart failure were readmitted within 30 days. For instance, another famous study by Vamosi and his colleagues in 2020 showed that 36 of cardiac patients with comorbid depression got readmitted within 1 year after discharge. The comorbidity of depression and its consequent increase in readmission rate leads to staggering healthcare costs. Listen to this. In 2009 alone, approximately $172 billion was spent in inpatient hospitalization for mental health conditions alone. Mental health conditions alone. Readmissions has been portrayed as the main element in controlling healthcare costs. Frequent readmissions can expose individuals to more harm and diseases, and it can lead to further decline in the individual's ability to cope in the society. High readmission rate creates enormous disruption in the family system and it adds enormous stress to patients, leading to decline in patients' condition and further deteriorations. The high cost of readmissions has led to reduction of reimbursement by Medicare as a penalty and as a means to ensure that effective and quality affordable care in the medical hospital were provided in some conditions like in congestive heart failures. Such proposals are actually being discussed in the mental health. In order for any facility whatsoever to thrive in this competitive and ever dynamic healthcare field, each facility must devise means to reduce costs and produce affordable, quality, and effective care to individuals. This particular mental health facility that the project was carried out has high readmission rates. The facility treats mostly substance use disorder, and we can actually see how the use of substance can be an escape for dealing with depression. Some get readmitted in a question of few hours after discharge and are mostly termed frequent flyers by staff, just a way to show you that the person is always there. When you talk to some of these patients, most of them complain that all their problems were not being dealt with or addressed at their initial admission. Some will tell you, I just came, took care of my alcohol, I went home, I realized that everything wasn't taken care of. Then I'm back here. Therefore, these negative factors warranted investigating whether prompt screening for depression of all patients admitted to this facility, irrespective of their chief complaints, will help in reducing the readmission rate. As literature shows that prompt screening and early intervention for depression helped in the reduction of readmission risk of patients within 30 days following discharge. Okay, what are the specific aims for this project? Some specific aims for this project are: 1. To reduce the 30 days readmission rate, which will in turn improve patients' outcome by reducing the stress, the disruption, and the financial burden caused by readmission. The overarching goal is to help in reduction of the healthcare cost in general, and thereby, when all these negative effects are controlled and taken care of, there will be an enhancement in the quality of life of people in general. So, how did we do this? How was this project carried out? This project utilized the quantitative exploratory design through a retrospective chart review. The study was carried out in an inpatient psychiatric adult unit in the Midwest region of the US. The facility name is purposely withheld in order to protect the identity of the participants. A total of 675 adult patients' charts were reviewed through the electronic health records. The quick inventory on depressive symptomatology, SR16, which is a 16-item questionnaire assessing depressive symptoms, was the instrument used for this project. Literature supports the instrument's validity and reliability for different populations, like it was used among college students, it was used in a particular population like the veterans with post-traumatic stress disorder. It has been utilized in different ethnic groups. It has been used in different ages like the adolescents and the elderly. And this instrument has been transformed into different languages, and it can be used in every setting, including the primary care setting. It's easy to use and it's quick. Prior to this intervention, a general depression assessment is embedded in the Columbia Suicide Severity Rating Scale used by this facility for admission process and assessment. And further assessment is always warranted when patients have depression as one of their principal diagnoses or as one of their diagnoses. A pre and post intervention design was used for this project, where the number of readmissions were obtained 3 months prior to the implementation of the project and then 3 months after the implementation of the project. Prior to this implementation of this project, the staff were trained on the use of this instrument. And the intervention requires screening every patient across the board, irrespective of their chief complaint or history. The EHR was used for this project. So the instrument was embedded in the EHR, that's the electronic health record, utilized by the facility. And confidentiality was ensured for this project by de-identifying the data, removing every identifier for this data, because breach of confidentiality was the only foreseeable risk for this project. And this is data collected. This is a chart review, and data was collected retrospectively, and no patient was actually engaged. The data collected were analyzed using disease statistics in comparing the post and pre-admission rates. So what does the results show? The participants were actually grouped into two. Group 2 were termed the pre-intervention group, and they had a total of 323 encounters. And the number of readmission within 30 days were 49. And the rate of readmission was determined to be 15.17%. The post-intervention group, Group 1, had a total of 352 encounters, and 55 were readmitted within 30 days, and the rate was determined to be 15.62%. And using the 2-tailed statistics, the p-value was determined to be 0.5649. So let's talk more about this result. What does this result mean for this project? What does this data mean? Let's crunch the data. This result indicates that there are insufficient information to suggest a decrease in the 30-day readmission rate in this facility. Looking at the p-value of 0.5649, it is greater than the significance level of 0.05. Therefore, the null hypothesis is now rejected. The confidence intervals suggest the true change in ratio from pre to post intervention. And so, since 0 is included in the interval, we do not have significant evidence to show a change in one direction. The achieved power of this study is actually 0.0691, which is considered low as opposed to the 80% that is expected. So let's talk about factors that played role in this project. This study did not replicate the studies in the literature as the aim was not fully supported. Some limitations that may have played role in this is that this is a single site study, so generalizability is an issue here. The results should be interpreted with caution because it is from a single unit of a hospital in the Midwestern region of the United States with minimal diversity, comprising primarily of whites. Also, the impact of other disease morbidities was not accounted for in this project. Though depression was thought to contribute to higher readmission rates, other variables like the length of stay and other illnesses that could contribute to 30 days readmission were not accounted for in this project. Though this study did not utilize enormous sample size, but the size is reasonable compared to other studies. So that is kind of a positive thing about the study, as like a strength. Looking at this slide, you can see a graph showing the total number of 30 days readmission and total number of encounter. The yellow, the mustard yellow or orange shows the post-intervention group, and the blue shows the pre-intervention group, just for visual sake. So what are the implications for these studies? This study has helped in creating awareness of the prevalence of depression and its impact to patients. Depression is now tagged the sixth vital sign, and appropriate screening for this illness should be mandated by all facilities. The goal of nursing care and healthcare in general is to deliver effective and affordable quality care. And prompt screening is a factor to ensure this. Since this data is collected electronically, it ensures better data integrity, and patients administer the tools by themselves because it's a self-report. It ensured that the dignity of the patient was preserved, and it was done in a judgment-free environment. This will ensure the true data, as patient has no need to create a false information. Prompt screening and assessment ensures better outcome for patients and in general reduces the healthcare cost. So what are the implications for future research? This study has actually set the foundation for detailed depression screening, the reduction of the revolving door phenomenon. If you take a look, let me go back to the first screen. You can see the hospital, the entrance and exit to the hospital. This is what is known as the revolving door phenomenon, where you see people exiting and entering. So for us to stop this revolving door phenomenon, further research is needed to determine if detailed screening with this instrument called a quick inventory of depressive symptomatology with follow-up on compliance of patients for the treatment recommendation which will require more of case management, like following up to see if they actually went for the treatment that they were supposed to, like the referrals, whether they followed up with that, will help reduce the risk of the 30-day readmission. Also, future studies should include vital social factors such as socioeconomic status of patients, which can be a huge factor in patients' high utilization of inpatient mental health facilities. For instance, this facility treats a lot of homeless patients, and during the winter season, you find out that most homeless people, when the shelters are full, they utilize the inpatient unit as a shelter for themselves. These are the references. Please, if you have questions, let me know. And thank you so much for your time and attention. Before I finish, I would like to thank my co-investigator for this project, Dr. Joshua Nadir, and my chair for this project, Dr. Mikel Elber, for your constant feedback and guidance. Dr. Nadia was a big facilitator for this project. I appreciate all your help. Thank you once again for taking your time to listen to this presentation, and I hope you gained something from it. Thanks.